Today I'm going to talk about Ogilvie syndrome, and this was a very atypical presentation, and it was also not well thought when we were initially managing the case. But we did come across this, and I will discuss in detail how the case presented. So, this was about a 50-year-old female who comes from a nursing home, and she complains of abdomen distension, and she was on G tube, and her G tube was displaced, and she had multiple episodes of vomiting. Besides that, she did not give any other history of confusion, dizziness, sweating, palpitation, chest pain, not significant for us. But she did have a history of a cerebrovascular accident, that is stroke, that was secondary to ruptured berry aneurysm, and which was the reason why she was put on G tube, as she failed to pass the swallow test. And she had a history of chronic thromboembolism, and she was also on an IVC filter. She had other underlying comorbidities like hypertension, and she had dysphagia and causalgia present in the right lower limb, and she was on multiple medications. So it was pretty apparent for us that this could be a case of simple electrolyte imbalance or multiple drug interactions or polypharmacy use that could have precipitated abdominal distension. And also, you usually think about nursing home patients who come with fecal impaction, chronic history of constipation, presenting with findings that are pretty similar to abdominal distension and multiple episodes of vomiting. And so we examined this patient. She was in distress. Her abdomen was distended. The G tube was in place. It was not, in fact, dislodged. She thought that maybe it was the G tube which was dislodged, and that has resulted in the similar findings. But so we decided to start her on a conservative modality and ran few tests on her, which was basically looking for some electrolyte imbalance, correcting her dehydrated status, and also looking for symptomatic resolution. This is what you usually think of any person who's coming with abdominal distension, usually in terms of fecal impaction, constipation, or dyselectrolytemia, or in some cases, drugs, which can also cause anticholinergic drugs, which was pretty apparent that her polypharmacy use and multiple medications from her underlying comorbidities, that we did suspect that it could be the underlying cause for such condition. So the initial test revealed that her metabolic panel was not that deranged. Her sodium was 135, her potassium was 3.3, slightly on the lower end, but not that much. And her creatinine was zero point 0.9. And usually you also look for underlying thyroid problems. So you run a TSH, and the TSH was in reference range. As an initial evaluation, you also look for any markers of inflammation or sepsis in the body. So ESR, procalcitonin, all of these were sent, and X-ray. Sometimes infections can also precipitate the same. So we did do the initial evaluation, and nothing much came out except for the fact that the X-ray abdomen acute series erect revealed that there was diffuse dilation of large bowel. And so she was started on IV fluids to correct her dehydration status, and also her potassium was corrected by starting on potassium phosphate. NG suctioning and putting nil per oral, these are the basic normal things you do for any person who's coming with abdominal distension, giving her DVT prophylaxis because she had chronic thromboembolism history, and also running a urine drug screen, because opiates are notorious to cause constipation, abdominal distension, and in fact to such extreme levels that it can result in severe abdominal distension of such kind. So the imaging that was revealed showed diffuse dilation, and also that one thing that comes in our mind when you see such dilated diffuse colon is that there is a possibility of impending perforation and person going into septic shock. So the management basically was conservative, and she did have less episodes of vomiting, and she was feeling significant better, but her repeat imaging did not resolve the distension in the large bowel. And so colonoscopy was done to decompress her bowel. But the exclusive finding that was seen in her X-ray erect abdomen, in fact, was that part of her bowel was actually between the right diaphragm, and that was present between the right diaphragm and the liver, that gave an appearance of pneumoperitoneum, or ruptured small bowel that could have resulted in pneumoperitoneum. That was exactly not pneumoperitoneum. That was reported by radiologists as an atypical finding, where the bowel becomes superimposed or comes between the diaphragm and the liver, giving an appearance that this is a pneumoperitoneum. That was Chilaiditi sign. This was another finding that was seen in her simple imaging. So this was basically a diagnosis of occlusion, and Ogilvie syndrome is a rare condition. And after having ruled out common etiologies like toxic megacolon, which could happen from Crohn's disease, ulcerative colitis, she did not have any history of uh, bloody stools or any chronic inflammation. Her colonoscopies recently, which were checked, were normal. So it did not reveal anything that was suggestive of inflammatory bowel disease that could also present with toxic megacolon, or infection that could be Clostridium difficile infection that could induce a colitis and produce the same. Regardless of that, you should also keep in mind that atypical conditions like Chagas disease can also cause the same megacolon and result in the same findings. But this requires usually extensive diagnosis, an extensive workup to give Chagas disease. She did not have any other underlying risk factors to suspect that, and she did not also have any history that suggested that she was in an area that predisposed her to develop the Chagas disease. So this was about Ogilvie syndrome, which basically is a disorder that happens due to abnormalities in the peristaltic movements within the colon. And these involuntary rhythmic muscular contractions that happen in the colon are under the autonomic regulation. This is important for propelling the food and also the waste material. The underlying cause for Ogilvie syndrome is not understood well, but the risk factors can be from prolonged immobilization, an unclear association with cesarean deliveries, electrolyte imbalance, polypharmacy use, and severely ill patients, or those who are having a lot of metabolic derangement, hospitalized patients, and a rare association with a condition called atrophic visceral myopathy, where the smooth muscles which are present in the colon, or in fact in the entire gut, they can become atrophied because of some plexus, ganglionic plexus involvement, but there is absence of any inflammation. The pathology for this is poorly understood, but it can also be from spinal anesthesia, secondary to spinal anesthesia and trauma, because these are usually affecting the parasympathetic S2, S3, and S4 fibers, and these can potentially induce the autonomic dysregulation and precipitate the same. The findings can be either constipation, or sometimes paradoxically it can also result in diarrhea and resulting in fecal potassium loss, severe hypokalemia that requires immediate correction. Nausea, vomiting, bloating, or any other form of mechanical obstruction, all of these should be ruled out. It is very important that any abdomen distension, you have to rule out an underlying mechanical obstruction for it first. So the X-ray abdomen acute series did not reveal any such pathology. The TSH was within reference range, and so we thought that this could be because of Ogilvie syndrome. Now, this dysregulation in the autonomic nervous system is basically going to cause decrease in the activity of a stimulatory gut neurotransmitter, that is acetylcholine, and which is the main reason for sluggish peristalsis and distension and dilation of the loop of the colon. Now, this dilated loop of colon is very important for us because there is a critical diameter that should be looked for, that if the cecal diameter is less than 12 centimeters, then conservative modality of treatment is the best first management. But if the dilation of the cecum is more than 12 centimeters, then this can be a sign of impending perforation. And in the initial 72 hours, you should have a very high suspicion for impending perforation if the person is acutely toxic or is having a diffusely distended abdomen that is going into guarding rigidity, that can present with something that is indicating that this can go into peritonitis secondary to perforation of the colon. So, Ogilvie syndrome is to be kept in mind only after having ruled out other functional disorders of colon as well. Diabetic gastroparesis can also cause the same findings. It can cause diffuse abdominal distension and variable symptoms. Irritable bowel syndrome, which is typically common in middle-aged females. Gastroparesis, as we already spoke about, and a condition known as chronic intestinal pseudo-obstruction or functional dyspepsia, cyclic vomiting syndrome, or in fact, substance abuse, as already mentioned, opiates, cannabis, marijuana, all of these can also do the same. Now, most of the times, conservative modality of treatment within first 72 hours should cause significant improvement, and using colonoscopy or rectal tube decompression should work for most of the patients. But for those patients who are failing to improve, then uh, drugs can be used like neostigmine, and this is basically going to be a pharmacological management. Usually neostigmine is avoided in patients because it is important to also assess for possible bradycardia that could be induced in the patient when you're treating with neostigmine. And giving multiple doses also, there are very unclear studies about the usage of neostigmine. But for those patients who are not going into resolution, the best next method is going to be decompression using colonoscopy. That is ideal. And in summary, it is very important to keep in mind that the more common etiologies like toxic megacolon from Crohn's, or in fact colitis from C. difficile, these are to be put in mind for those patients who are coming from nursing home. So I would like to thank Dr. Rakas Burney and California Research Institute for giving me an opportunity to present this very atypical case. And I hope that this helps anybody who has come across or something like this. Thank you.